Good morning, everyone, and welcome to today's COVID-19 Community of Practice for Ontario Family Physicians. My name's Ali Damji, and I'm a family physician and division head of primary care at Trillium Health Partners, and I'm from the Department of Family and Community Medicine. The DFCM and the OCFP are pleased to continue to be offering these sessions, and we're so happy to be presenting today on an infectious disease update and the approach to ADHD. Next slide, please. I'm going to turn things over to Dr. Mekalai Kumanan, president of the OCFP, to introduce the session.
Good morning, everyone. Happy Friday. Thanks for joining us. We have a great session lined up, and I'd like to just take a moment to thank our speakers for being with us today. And I'll move on to our land acknowledgement. So we acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have a rich cultural and traditional practice that have been known to improve health outcomes. I invite us all to reflect on the territories we are calling in from as we commit to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I'm calling in from Kitchener, the lands traditionally used by the Haudenosaunee, the Anishinaabe, and the Chinantan peoples. Next slide. So I wanted to just take a moment to reflect. I think we all know it was Earth Day this past Monday, and just a nice chance to celebrate our planet and reflect on ways in which we can protect it. For me, I just tried to take a little bit of time this week to learn more about Indigenous people's relationship to the land and how they have been stewards of our land for thousands of years. And I stumbled upon an article that you'll see on this slide that outlined some of the books to read this year for Earth Day. And this one in particular stood out to me. It's called I'm a Rock, and it's a picture book by Ashley Killivack-Savard. She's an Inuk writer and an artist from Iqaluit. So essentially the book's about a little boy named Policy who has a pet rock, and he lives in the Arctic. And at bedtime, he asks his mom what rocks would say to us if they could speak. And so the book describes essentially what Policy's rock sees, feels, and hears as part of the land in the Arctic. And the rock describes everything from the wind to the animals to the northern lights and much more. And so for me, it was just a really lovely reminder of the connection that Indigenous people have had to the land for years, and kind of an important reminder for us to continue to learn about environmental stewardship, and a nice book to help us teach our children to do so as well.
So in terms of today's session, it's fully Mainpro accredited, and we want to just also make sure that we mention that the session will also be recorded and the Q&A will also be posted. Next slide. We have a wonderful set of panelists today, and really looking forward to an engaging discussion on two really important topics. So I'll have them introduce themselves in just a couple seconds. Next slide. So at this time, I'll turn things over to each speaker in turn, just to introduce themselves and briefly speak to their financial disclosures. So first up, Dr. McGeer.
Morning, everyone. Ali, this sound is okay?
Yep, you're good. You're good.
Okay. I'm Allison McGeer, Adult Infectious Diseases at Sinai Health. And you can see from my relationships that I work with a lot of the companies that make both vaccines and antivirals for flu and COVID. Thanks.
Great. And over to you, Dr. Flood.
Good morning, everyone. I'm Joan Flood, and yes, I work for some of the pharma companies that produce ADHD medications or are hoping to develop new medications for our market. And I'm also a board member of CADDRA, the Canadian ADHD Resource Alliance.
Thank you so much. Mekalai?
Hi there, everyone. My name is Mekalai Kumanan. I'm a family physician in Cambridge. I'm currently serving as the president of the Ontario College of Family Physicians and the deputy chief of family medicine at the Cambridge Memorial Hospital. I do receive a stipend for both of those roles, but neither of them poses a conflict for today.
And for myself, I already introduced myself at the beginning, and I receive financial support from the OCFP, and I also receive a stipend for my role at Trillium Health Partners as division head, neither of which pose a conflict for today. Next slide. So just as a reminder for our participants, when you want to ask questions, please put them into the Q&A section, and I see several of you have already done so, which is wonderful. If you have a question, please open up that box, and if you see a question that's already been asked that's similar to what you wanted to ask, rather than posting the same question again, please just use the upvote function. The most upvoted questions will be the ones that I ask. And of course, we encourage you to use the chat to network and to discuss what's going on in the session today. Next slide. All right, so we'll kick things off first with Dr. McGeer to give us our infectious disease update. Next slide. Over to you.
Thanks, everyone. I've just been sitting here thinking that even I, and I am a known pessimist, did not think that I would be talking about COVID 4 years in. So I'm sorry we're talking about COVID 4 years in, but at least it's getting better. I just want to talk for a moment about the fact that Ontario, although not other provinces, is actually seeing a bit of an increase in COVID. So top left of this slide, you can see the wastewater signal. And if you just take it down to just one click so we can see the next thing on the slide. You can see that the tilt up this week in wastewater is larger than it was last week, which is just a tiny bit depressing. And the bottom right, you can see COVID deaths, which is in my view, the most reliable indicator. You can see for the first time in 8 weeks, there's been a little bit of a bump up. So not awful, but a useful reminder that for those of us who are over 65, have underlying medical conditions, are immunocompromised, it's still worth getting the spring booster. And the spring booster is out and available. So if people are asking you, the answer is still yes. You should be getting your spring booster because we don't know what's going to be happening. And as previous speakers have said in the last few weeks on this call, we're running efficacies for the COVID vaccine of between 40 and 60% against hospitalization and a little bit less against any infection for this last booster. So the other news of the week this week, next slide, is that NACI has posted their recommendations for the 2024 COVID vaccine, right? We're moving to annual vaccines. We'll see whether we stick with them, but we're definitely sticking with them for this year. No surprises in what their recommendations are. As always, there's strong recommendations from NACI and discretionary recommendations, and in the strong recommendations should be vaccinated adults over the age of 65, residents of long-term care, people with comorbidities, pregnant women, individuals from First Nations, Métis, and Inuit communities, other adults who are at higher risk than many of us, and essential service providers, which includes healthcare workers. And then in the maybe vaccinated, it's everybody else over the age of 6 months. So fairly standard recommendation, right? Looks a lot like influenza going into the fall. Next slide. And there are a couple of other useful things in this statement. For the first time, NACI's done cost effectiveness estimates, and their estimated cost effectiveness for this vaccine is just over $8,000 per quality. So that is two things about that. First of all, it's well within the cost effectiveness range of things we do. And secondly, it's a marker that even though COVID is a lot better, it's still worse than many other things. And despite the fact that these vaccines are moderately expensive, probably not that expensive since the feds are paying for them on big contracts, but still probably more expensive than flu vaccines, still a cost-effective thing to do. Second thing that NACI has said is that they're suggesting that we set what they call a clear minimum interval of 3 months. And that's their attempt to say, when we go into the fall wave, we're trying to make this a regular fall vaccine. So we're not going to have to be sitting in the fall and saying, well, yeah, it's been 5.5 months and you should wait 6 months for your vaccine, or you've been previously infected and you should wait. We're going to make a rule that says that you shouldn't get your fall vaccine if you've had a COVID vaccine within the last 3 months. But it won't matter whether you've had an infection in the last 3 months. And if you're between 3 and 6 months, it's still okay to get your fall vaccine. And that's obviously just because it's easier if we all settle into getting your COVID and flu vaccine probably at the same time or within the same range. And just a reminder that COVID vaccines can be administered with influenza pneumococcal vaccines or with the shingles vaccine. And there's enough data now for NACI to say confidently that you can administer them at the same time. 2 other small things. I see someone's posted in the chat the announcement for the FDA meeting. If you're, obsessed with vaccines as I am, you can listen to them, have a discussion about which strains going in the vaccine, right? Remember that we make that decision for flu because we make protein vaccines for flu in February, and it takes longer to make protein vaccines, but the decision for mRNA vaccines for COVID is the middle of May, and the FDA will make that decision, and WHO and the European Regulatory Agency have meetings at about the same time, and we will decide what's going in the fall vaccine. The second thing that may be a little bit useful is there's a new U.S. NASM, that's National Academy of Science, Engineering, and Medicine report, so an independent report on COVID vaccine safety. You can read all 200 pages of it if you wish to, but it's just, an independent body review confirming the fact that there's 2 things that you can get with COVID vaccines. If you're young and male, you can get myocarditis, and any intramuscular injection in the shoulder can cause local damage if it's misadministered. So next slide. The next question is, when are we expecting the next COVID wave? And I think even the NACI statement says, we're expecting the next COVID wave in the fall. And it is true in Canada that our COVID waves have, in general, started sometime in the fall. But you remember that last year started in August. And I just wanted to put up the slide of Australia. So on this slide, the blue bars are winter, it's cold. The red bars are summer when it's warmer. And you can see in Australia, there's really not a good correlation with winter waves of COVID-19. And you would expect there to be if we're going to see standard winter waves in Canada. So it's fine that we're working on, biannual vaccines. But we just need to be a little bit careful about assuming that we're going to have a nice, quiet summer. And again, I think what that means is that if people are traveling this summer, not unreasonable for people to get a dose of vaccine before they go so they don't have their holiday ruined by getting COVID while they're trying to enjoy themselves. Next slide. Okay, 2 other things about what's going on with COVID. The Paxlovid supply from the federal government, as you know, is on its last legs, and at the moment we're using up the renal supply of nirmatrelvir ritonavir. That should last us comfortably until the end of May, at which point in time the province will take over supplying the drug. For recommendations, the CADDRA coverage recommendation is coming out today. And I'm told that the provincial recommendations will be out in about the second week of May about what the provincial government is going to cover for people for this medication. We'll see what happens. The second issue is about masking, and just a note to say that across hospitals in Ontario, in the last couple of weeks, virtually all of us have backed away from universal masking for care provision in hospitals. There's a lot of variability in whether people are sticking with universal masking in some areas. So some people are doing it in their emergency department waiting rooms that are really crowded. Some people in their neonatal intensive care units or in their transplant units. The units themselves have decided they still want to be masking. So we're at the stage where I think people are feeling that it's absolutely fine if people are feeling at risk for particular reasons to be saying we can continue masking, but we're probably also at a stage where if people are comfortable in care without masks, that it's okay to take masks off. And just because I did infection control for a long time, I want you to think about N95s and what the issues with them are. So this is a mask that is sold as an N95 mask, and the picture on their website has this gentleman wearing it, and you will recognize, if you're paying attention this early on a Friday morning, that this guy's got a beard. And the moment you have a beard, you don't get a seal with an N95 respirator, and there's no point in wearing something that's called an N95 unless you have a good seal. So it's fine to wear N95 respirators or masks, but you don't need to waste your money or your illusions on an N95 respirator that isn't any better than a mask. And now, from the sublime to the ridiculous, next slide. What's this about cows? Okay, so the news this week, for those of us who are into infectious diseases, has all been about H5N1 in cows. And the reason that this is a big deal for people is that cows don't get influenza A, it turns out, okay? There's an influenza D in cows, which has recently been discovered, but really doesn't make them sick. And so nobody was ever expecting that cows were going to get H5N1. But about 6 weeks ago, people identified an outbreak of H5N1 in a herd in Texas, and things have been expanding from there. And where we stand now as of yesterday is that yesterday there were two announcements, one from a research group in Ohio and one from the U.S. Department of Agriculture, saying that they had tested commercial milk, retail milk supplies across the state of Ohio and across the U.S., and between a quarter and 40% of them were PCR positive for H5N1. So there's a no news, good news, and bad news about this, okay? What this tells you is that there's a lot of H5N1 infection in cattle at the moment, that is widespread across the United States, and that we really didn't notice it happening. Not surprising, right? Because cows get a lot of respiratory infections, and since they don't get influenza, nobody thought about influenza until very late in the game. That is natural. So the no news about this is we don't need to worry about milk supply, okay? What is being tested for, right, is RNA viruses. That's what PCR detects. What would matter would be live viruses in milk, and there's no indication there's live viruses in milk. And the list of reasons not to worry are, okay, first of all, H5N1 is a regular influenza virus from the status of disinfection and pasteurization should kill it. Secondly, remember that when you get your milk, it's a milk from a large number of farms at the same time. So there's a huge dilution factor that goes into milk from a particular farm that might have an outbreak of H5N1. Third, of course, we don't get influenza from ingestion. You get influenza from inhalation, and we don't aerosolize our milk, right? We drink it. So the combination is there's absolutely no reason to worry about the milk supply from the perspective of having it be positive. But it does tell you that infections are widespread in cows, and there is evidence that there's cow-to-cow transmission, but there's also been evidence that outbreaks on dairy farms in the United States have resulted in this virus going back to other poultry farms in the neighborhood, and that, of course, is bad news because it tells you just how versatile this virus is and how capable it is of adapting to different species and causing really unusual things. That's the bad news piece of this being in cows, okay? It's making everybody uncomfortable. But there is a silver lining to this, and the silver lining to this is clearly these infections have been going on in cows for months. There's a lot of them, and we've still only seen one human infection, and that was mild. And so the fact that we have a lot of infections in cows and no human infections is really reassuring. And you'll say, how do we know there are no human infections? And the answer is, of course, at least at hospitalization, we're testing everybody with respiratory symptoms because we have to test them for COVID. And pretty much all of our tests test flu, COVID, and RSV because that's just how they make the tests. It's not more expensive to test 3 than it is to test 1. And our regular flu tests will detect H5N1. And generally, they'll tell you that it's not seasonal flu, that it's something else, and then you go on and do the specific testing for H5N1. And yet, we're coming to the end of flu season, everything's settling down, and nobody has identified somebody who's got a positive flu test that isn't seasonal flu so far. So, keep posted. H5N1 is continuing to do unexpected and anxiety-provoking things, but still nothing to tell us that it's going to be causing a problem in humans anytime soon. Fingers and toes crossed if you're into crossing your fingers and toes. And that's it for me. Thank you. Oh, wait. Sorry, one more thing. Yeah, just because I'm a microbiologist and I can't resist phylogenetic trees, just a marker that you see that all of these sequences that are kind of blurry are really tightly clustered together. So this was one event of transmission from a poultry to a cow and then expansion in cows. And so all of these infections are one particular strain spreading really rapidly through cows. This is what flu does, right? Only usually it does it in humans, not cows. Anyhow, just keep an eye out and hope that we're not going to get into trouble with humans, or that if we are going to get in trouble with humans, that we're going to have the same problem we have with cows, which is mild infections, right? That's the other reason to kind of be hopeful about this. Thanks.
Thanks so much for that amazing and rapid fire update, as always, Allison. Much appreciated. And with that, we actually have a little special announcement that we wanted to share from the team at the Community of Practice. So I'll turn things over to Mekalai to share the news.
Thank you, Ellie. So some of you may be aware that our very own Dr. McGeer has been announced as a 2024 Medical Hall of Fame inductee. And on behalf of family physicians across Ontario, I would like to take a moment to extend our sincere congratulations to Dr. McGeer today. I think for those of you who join our Community of Practice regularly, you'll know that Dr. McGeer has been incredibly generous with her time over the past many years. And Allison, I just want to say we have so appreciated how much you've taken time to support primary care through the pandemic and otherwise. We're incredibly grateful for your knowledge, your expertise, and I think most of all, your common sense approach to managing COVID and other infectious diseases. And it really has been an absolute pleasure working with you. So congratulations from all of us.
Oh, I think we might have lost her audio again.
Sorry, I just want to say we are in this together, and family medicine and primary care has been amazing and awesome throughout the whole pandemic. It's been a real pleasure watching it and working with everybody. And let's just hope that this is over soon. But the last thing I want to say is I've learned so much on this Community of Practice about so many things. It's really been a wonderful experience. Take care.
Thank you so much, Allison, and congratulations as well from all of us. So next slide. And Allison, you'll see a lot of appreciation too from your colleagues here as well too. So please feel free to take a look through the chat. I'm going to turn things over again to Mekalai for this.
You heard it from Allison. She's hopeful this will be over soon, but I'm not going to hold her to that. Okay, just shifting gears for a second here. I wanted to touch on the ministry announcement that happened this Wednesday. So the OCFP was invited to attend along with the OMA and Ontario MD, as well as with family physicians from the Southeast Toronto Family Health team. So this announcement, the government introduced or is telling us that they will be introducing legislation that if it does get passed, it will no longer require employees who are sick for 3 days or less to obtain a doctor's note. And what we've heard from family physicians across Ontario is that this is one area that does take up time and uses up appointments in our schedules, especially sort of same day, next day appointments. So we've been advocating at the OCFP for sick note elimination for some time now. At this announcement, the government also introduced a new pilot where they'll be using AI scribes in more than 150 primary care practices during patient encounters, and hopefully that will expand over time. So just wanted to flag that to all of you and say we're looking forward to hearing more details about both announcements. I know these are small steps in the right direction and that there's a lot more that needs to be done to address the administrative burden that we face in primary care. And we certainly won't stop advocating for continued changes from the OCFP.
Sorry, I had a situation with my audio there too. Thank you so much for that update there, Mekalai. We'll do one more slide and then we'll move over to Q&A. This particular slide pertains to the Vaccine Injury Support Program, which is a federal program that's available for patients to potentially file claims if they have had an injury related to a vaccine. In terms of the specific criteria for it, the vaccine has to have been administered in Canada on or after December 8th, 2020. And if the patient experienced a serious or permanent injury as a result of receiving the authorized vaccine, they may be eligible for financial support from the federal government. The reason why we're flagging this is that if you do have an eligible patient, they may ask you about their eligibility for the program. And if the patient submits a claim, you might be asked also to complete a medical assessment form or provide medical records so that the claim can be verified. So we just wanted to flag this because this is a program that exists. It's not just for COVID vaccines, it's for any vaccine that's used to prevent a type of infectious illness. So just keep that in mind as well. And it has to be a permanent and serious injury that was caused by that. So with that, we'll take down these slides and we are going to move into Q&A. All right, so in terms of the Q&A, so the first question here actually is pertaining to Paxlovid. And I know you mentioned a bit about the supply issues with Paxlovid, Dr. McGeer, but wondering about the kind of thoughts that are out there that that Paxlovid may not be better than placebo.
So I don't understand why this is true, okay? There's a bunch of things I don't understand about Paxlovid, but what the recent trials tell you is that Paxlovid does not reduce your days of symptoms or your severity of symptoms if you're going to recover anyway. That does not mean that it doesn't reduce your risk of hospitalization, and there does seem to be this discrepancy between Paxlovid making you feel better faster and Paxlovid keeping you out of the hospital. And it's the same problem that I have understanding, right? If an antiviral medication works to treat you, an antiviral medication should work for prophylaxis, right? And Paxlovid does not work for prophylaxis. So to me, what it's telling me is there's something we don't understand, that what gets you sort of regular upper respiratory symptoms with Paxlovid and what gets you into the hospital with severe lung disease are two different things. And Paxlovid prevents the severe disease, but it doesn't make you feel better faster if you're not going to get severe disease. So to me, those new trials don't alter what we should be doing with Paxlovid, which is reserving it for people who are at risk of hospitalization with the goal of reducing hospitalization. But that of course, is not easy to do in the setting of, how many vaccine doses you've had and when you last had COVID and how we decide on things. I think it's clear that people who are seriously immunocompromised are much more likely to benefit from it than other people. I think if it's me, I'm still in favor of treating people in long-term care, because even though it's much better in long-term care, there's still probably running a 2 or a 3% mortality rate, and that's uncomfortably high for me. But it does make it really hard to judge when to use it for other people.
Yeah. Thank you so much for that, and that clarity as well too around the specific populations, because I think that's that really important nuance there as well. So another question here is about if you can give us some updates around the long-term risks of repeated COVID infections. Are there kind of long-term risks that we're seeing, potentially neurological effects or other types of things similar to other types of viruses?
So I don't think we're seeing anything at the moment. We're in that phase where people have enough immunity now from multiple COVID infections and from multiple doses of vaccine that the severity of illness is declining slowly. And I think so we really are moving to a time when getting COVID is not going to be different than getting influenza, or hopefully getting an enterorhinovirus infection. Like we haven't figured out where the plateau is going to happen with severity of COVID infections. As that happens, right, when you have a new viral infection to which everybody's susceptible, those first infections are associated with, they have been in previous severe flu pandemics and other pandemics. They're associated with what we think of as long COVID symptoms. They can be associated with a bunch of other complications. But as the whole population becomes immune, those complications go away. So I think we can, I don't want to minimize COVID infections, right? People are still dying every day in Ontario from COVID infections. But it's also true that your risks of something bad happening to you in terms of long-term complications are declining steadily. And getting a COVID infection, getting COVID infection in 2020, you were right to be worried about, a 20 or 30% possibility of long COVID and many other complications. Getting a COVID infection now, getting closer to being something like getting influenza, unpleasant, sometimes acutely serious, but probably not associated with long-term adverse events.
Thanks for that. And that actually ties in really well to another question I saw in the Q&A, which was about, the vaccine approach. So I know you had mentioned that, NACI is talking about a 3-month interval. But at the same time, would it be reasonable to vaccinate every year, just like we do with the flu, to make it easier, right? And to just have it as an annual vaccine? Maybe there's a component to a vaccine burnout that patients, when they're told to come in every 3 months to get it, it kind of turns them off of it. So has there been any thoughts about that, or with our current vaccines, is that even possible?
So I think what NACI is doing is NACI is setting a 3-month minimum interval because they want us to move to a regular annual vaccine. I'm still hoping, that we are not going to need a regular annual vaccine for COVID, that once we get far enough into this, COVID is going to be mild enough. It's really going to be not more severe than an enterovirus infection, and we're not going to need annual vaccines. But we're not there yet, It may take 5 or 6 infections to get to the state where you get really mild infections when it happens. And as long as we're not there, it is much more effective, as you say, if everybody knows what the rules are and if the rules are really simple. And the simple rule for COVID is getting your COVID vaccine with your flu vaccine in the fall. So we sort of tried that last fall. But then everything was complicated because you had to say, okay, so I'm going to get my COVID and flu vaccine, and the flu vaccine is here, but I can't get my COVID vaccine today because it's only been 4 months since I had COVID, and so I have to wait 6 months. So that means I'm going to get my flu vaccine now, my COVID vaccine later, and everything just got so complicated. In long-term care, you had to look at every resident one by one instead of just saying, you know, today is vaccination day and everybody's getting their COVID vaccine today. So what NACI is doing is trying to get us to that stage. And the way they're doing it is saying, okay, we're going to have a fall COVID vaccine program. It's going to be like the flu program. You can get your vaccine with the flu vaccine. It's going to be really simple. In order to do that, you have to say two things. First of all, you have to say, we're no longer going to care about when you got your last COVID infection before you get your vaccine. Doesn't matter when you last had COVID, you get your COVID vaccine in the fall. And the second thing we're going to say is you can get your fall COVID vaccine if your last vaccine dose was more than 3 months ago. Because, you know, so far we've had vaccines in the fall and vaccines in the spring, and that in general, people, you know, some of us are not as good at adhering to, you know, rules as other people, and so the vaccine doses kind of bleed into May and June. And if you get your vaccine dose at the end of May, it's not 6 months by the time October comes in order for you to have your regular fall shot. So if we make a rule that says a minimum of 3 months, then when the fall COVID vaccine comes, you make everything less complicated. You don't have to worry about when you had an infection. You just have to be sure that you haven't had a COVID vaccine until June, and then you get your fall COVID vaccine. And so now we've made the rule simple, and hopefully we can all adjust to that simplicity. And then the whole fall vaccine program will become just simpler and easier for all of us to cope with.
Interesting. Well, we'll definitely see how things unfold and with this new approach.
Yeah.
Fingers and toes crossed, as you said. So in terms of the next question here, so this one is that I've had a few young patients who are not high risk who got their COVID vaccine about 6 months ago and are now interested in getting another dose. My understanding is that for all patients who are not high risk, even if it's been more than 6 months, the recommendation is to wait until the fall. Is that correct, or can they get the dose now?
The only harm in getting another dose of COVID vaccine is you might get a sore arm and you might not feel well for a couple of days. And if somebody who's not at high risk chooses, right? So we have a vaccine recommendation that is still permissive from NACI and from the rest of Canada. So it says we're not asking you to encourage your 35-year-old patients to get their COVID vaccine. They don't need a COVID vaccine. They don't even need a COVID vaccine in the fall. But if people come to you saying, I don't want to get COVID and I would like my spring COVID vaccine, it's fine. They're not putting themselves at any significant risk of anything bad happening to them. And if they choose to, accept the reactogenicity of the COVID vaccine in order to avoid getting COVID, it's okay.
Thanks. Again, really practical advice, and I'm seeing some comments in the chat about that. So thank you for that. Another question here is about people who are economically disadvantaged, or even I would just say arguably a lot of people in the population that just can't access the testing kits. So now that we don't have them as readily available, how do we diagnose COVID now in the first place, or be able to, kind of approach this now?
So I think what we're probably needing to adjust to is that we're going back to a circumstance where, in the same way that we don't diagnose influenza infection in young people in the community who don't need treatment, we're not going to diagnose COVID in young people in the community who don't need treatment. And we're going to have this rule that says that, if you have an acute viral respiratory illness and you can stay home, we would like you to do that so you don't infect other people. But we're not counting on diagnosing every COVID infection, every flu infection. It's an uncomfortable transition because it's nice to have a diagnosis, right? We all like having diagnoses, and so it's been we've just all gotten used to the rapid tests. But we do need to wean ourselves off them because they're really not a cost-effective option. And as COVID becomes just another respiratory illness, it's important that we diagnose it when people are being hospitalized because we need precautions and we have different treatment regimens for people who are seriously ill. But it's not important to diagnose it in just everybody in the community. And so there's going to be this period of, I am sad to give up this piece of information, but I don't need it, so I'm going to live without it.
Yeah, and I think again that's that shift in mindset, as you said, right? As we move into this new phase of the pandemic. So yeah, that makes a lot of sense. Thank you for that. I'll ask one more question here, which is about children specifically, if you feel comfortable commenting on that. So children who have never been vaccinated against COVID, should they still be offered the vaccine at this stage of the pandemic?
Nancy says yes. Unvaccinated children should receive 2 doses of vaccine. So we're still in that phase where children have, if you like, not had enough infections. Not that I would wish any infection on any child, to be confident in their protection. And Nancy still is recommending that any unvaccinated child should get their 2 doses of vaccine.
Great. Thank you for that. So with that, we'll move to the next section of today's community of practice, which is focused on ADHD. But of course, Dr. McGeer, if you're able to answer more questions in the Q&A via writing, we can do that. And we'll also have additional Q&A at the end of the session and can go back to COVID. So with that, I'll turn things over to Dr. Flood.
Okay, thank you. Thank you very much. And first of all, I want to say how honored I was to be asked to join this very prestigious group, which I've listened to along the way, and to have my name sit on the same page with Dr. McGeer's is amazing. Dr. McGeer, you are so incredible in your commitment and to the people of Canada, and truly are medical royalty in our country. So it's an honor to present along with you, and I congratulate you. The other thing is I'm extraordinarily relieved that I can freely drink my low-fat latte every morning, which was one of the true pleasures of my life. Moving on, let's talk about ADHD. I have a number of slides and I'll go through real quick. So I'm going to try and talk about myths and facts. I could easily spend an entire weekend doing a whole course on this. We'll try and give you highlights. So facts: ADHD is a neurodevelopmental disorder, usually genetic in origin. 20 years ago, when I gave talks on ADHD, I used to have to tell people that ADHD is not a religion. And the reason I would say that, to get their attention, of course, was to point out to them that ADHD is not something that you do or don't believe in. It is a very real disease with very real disorder with very real neurodevelopmental underpinning. And we do see some changes on MRI scannings, volumetric decreases in the cerebrum and cerebellum, delayed cortical thinning and maturation of the cerebral cortex in youth, and abnormal connections in the cortical limbic system. And a pearl for you here, just to bear in mind, these are the same areas that are affected by cannabis use. So anyone who tells you that their ADHD is improved with cannabis, it's not. And what it comes down to is impaired synaptic release of dopamine and norepinephrine. And these two neurotransmitters are important in attention and emotional regulation, which is part of ADHD. Next slide, please. ADHD truly is a public health issue, not unlike cardiovascular and diabetic diseases. Russell Barkley, who is extraordinarily well known in the ADHD community and a beautiful speaker, has written many very solid books, did a review and study that was published in 2018 that showed that adults with ADHD have almost a 13-year decrease in estimated life expectancy. That's not unlike cardiovascular disease and diabetes. And further, prior to their demise, they have a number of years of reduced quality of health. So ADHD is linked to adverse consequences in nearly every major domain of activity in life to date. There are increased accidents and self-inflicted injuries, motor vehicle accidents, obesity, tobacco, alcohol, marijuana use, other substance use. They don't look after their teeth, dental caries, sedentary behavior, low rates of exercise, sleeping problems, migraines, poor nutrition, on and on. And people with ADHD often go through life with less education, less annual income, and the other issues that I've mentioned above. And they have behavioral traits that contribute to difficulties, impulsivity, poor inhibition, etc., which often get them into trouble. Next slide. Individuals with ADHD certainly do experience an awareness of being different. And if I had to tell you the one thing that I see in common with the adults I assess right now today is they're very shameful. And it usually takes them a while to come in and complain about their ADHD to you, but they usually come in at a moment where things are really getting difficult, and they really do need to talk about it, in my experience. They have trouble fitting in socially. They often talk too much, or they don't follow the cue of conversation. They don't necessarily recognize other people's points of view. They get frustrated with the multiple tasks that are required in life. A lot of marital and family challenges, a lot of marital breakup in ADHD, and a lot of parenting problems. ADHD parents really have a hard time managing their children, especially if their children also have ADHD. They have lots of trouble getting through school. They change jobs frequently. And as I said, lower income. Next slide. So the first question I got out of a list of questions here was, how can you approach it in a 15-minute visit? Well, you can't, but you can diagnose it in a few visits. And there's a few reasons for this. And I have an exclusive ADHD practice now, so I have the luxury of greater time, but I have also had a very busy family practice where I delivered 100 babies a year, et cetera, et cetera. How do you do it with 15-minute appointments? Well, see them for 3 or 4 appointments and let the patients know this is the way it's going to work. And this gives you a few things. First of all, you can spend a bit of time talking to the patient about it on each visit. If they really, a question I often get from primary care, how do I know they're not drug seeking? Well, if you set up a series of 3 or 4 appointments with them, and you make them do some work, and you make them bring in report cards, and you make them do stuff like that, they have to be persistent and really want that diagnosis and really want that treatment. So I also think that spreading the appointments out over a period of time gives you some assurance that the patient really is valid. So on the first visit, when the patient kind of comes in, or on their way out of the office, when they say, by the way, I think I have ADHD and it's Friday afternoon at 4 o'clock. If you have a minute, just get a quick history of the symptoms that are problematic and the impairments they have. Or say, we don't have enough time to discuss it today, but here are some rating scales I would like you to fill in. And here are some resources. And if you can send that out from your EMR, CADDRA has a very good site that can send this out to your patients. Do so, or maybe have a little package or something like that. All the rating scales I mentioned, plus more, are available on the CADDRA website at caddra.ca, free of charge. The SNAP scale, 26 quick questions, are very good for children, and I have parents and teachers fill those out. The ASRS is the adult screening scale. I have adults fill it out. If a collaborative family member will fill it out, even better. And the WISE functional impairment rating scale, I really love Margaret Wise's rating scales. They are available on the CADDRA website. They kind of give you the SNAP, the sort of PHQ-9, JD7, everything all wrapped up into one, with lots of questions on, even that refer to autism and psychosis and et cetera. So you get a really good review of psychiatric problems, and you can use the WIFRs in many other psychiatric situations over and above ADHD. And I give them a couple of resources. Quick, CADDRA.ca, which is a sister organization to CADDRA. It's a nonprofit organization, lots of great information for patients. I really love attitudemagazine.com. It's available from the US, so there may be information there that's not Canada appropriate, but Attitude Magazine can give a lot of information and helpful articles. Second appointment, spend a bit of time reviewing their history, family history, educational impairments, etc. And, take the questionnaires and tell the patient you're going to review the questionnaires. And the next appointment, next slide, I would spend a bit of time educating them about ADHD and options for treatment and psychosocial supports. So that would be, and I will quickly show you CADDRA's laminates so you can have a script for that, and maybe talk about accommodations for school, university, etc. And by the time they're back in for the 3rd or 4th appointment, whatever it is, talk to them more specifically about treatment options. And this is a good time to start medications. A question that I noticed in the chat was some doctors are just giving out here's some 5-ants, see if it works. I don't think that's right. I think you have to do a proper assessment, just like you would take a proper history for someone with depression or anxiety. And people often ask me, well, will I get into trouble with the college? The only person who ever got into trouble with the college for prescribing ADHD meds was giving doses that were so above the recommended limits that this person should not have been practicing medicine. But I do think that if you're prescribing controlled medications, you need to have a reason. Just flipping off a script for Vyvanse or Concerta to a patient, I don't think is appropriate. Next slide. So here are some myths. So people ask me, so where can I send them to a psychologist? A psychological assessment or a comprehensive psychological assessment is not the gold standard for an ADHD diagnosis. First of all, psychological assessments are not covered on the public dime anywhere. And they cost $3,000 to $4,000, which is not pocket change for the vast majority of Canadians, and they don't usually have enough coverage for it. Secondly, it's the clinical history and the picture of what's going on that really makes a diagnosis. The rating scales and the tests are adjunctive and supportive. Where you need a referral to a psychologist is if you're concerned about learning disabilities and if you're concerned about autism. And Russell Barkley, who is a psychologist, as I mentioned before, he has written an article that says, that is about psychological assessment does not diagnose ADHD. Like, we have to get away from sending patients for expensive psychological assessments. So keep that in mind. Next slide. So here are some key questions to help you tease out ADHD in adults. And you might want to take a screenshot of this. Have you had long-standing and consistent problems with attention and distractibility? So that will kind of help you pick up, the PTSD patient or someone who's had a death in their family. Like, was this going on 10 years ago, 20 years ago? Have the current complaints been present for that long? If another golden question is, if I could see you in your classroom, say in grade 5, when you were a child, what would you be like? Were you the class clown? Were you disruptive? Were you really, daydreaming all day and looking out the window and not listening to anything? What were you like in school? What would your teachers have told me about you? And here's my little pearl on this one. Really quick questions. Do they have a PDF file? Procrastination, distractibility, forgetfulness, okay? And are those things that have been present for a long time? Next slide. ADHD rarely occurs in isolation. Comorbidities are extremely common: anxiety, depression, substance use, bipolar, borderline, autism, learning disorders, PTSD. Why PTSD? ADHD people are often putting themselves in situations where they get traumatized, where they are abused, where they are raped, etc. They sometimes don't recognize the spidey senses. They do have more PTSD. They do have more difficulties at times. And here's a pearl here. Keep in mind that you may see the comorbidity before you realize that the underlying diagnosis is ADHD. They may be depressed or anxious because of their failures and inability to keep up in life. And I did have a peek at the questions prior to this, and there was a question about, how do you manage people with anxiety and ADHD? First of all, find out why they're anxious. And if they're anxious because they're not getting things done, they're not keeping up with their peers, they're about to lose their job, their marriage is falling apart, they have no relationship with their children, they're failing in high school, they're not getting into university, they're not passing in university, that's ADHD. And those same things may be causing them to be depressed too. Treat their ADHD. You're going to know in the next week or two if they're better. They may, if you're titrating the medications up fairly quickly. So definitely, don't wait and start by treating anxiety and depression if the anxiety and depression are due to what they're not getting done in their life. Move on. So here are a few quick clinical situations that happen here. So my patient used to abuse cannabis, so I can't use stimulants. Yes, you can use stimulants. Obviously, the substance use patient, and I'll talk to that a little bit later, but it is a challenge. But you know, when patients are on stimulants, they will frequently say to me, you know, I'm drinking a lot less alcohol. I'm smoking a lot less cannabis. A lot of them are self-medicating. So I do appreciate there is a line between the really serious addict and the person who is self-medicating. So you can use stimulants. My patient is middle-aged and hypertensive. I've had pharmacists refuse to fill scripts on hypertensive patients. What I've done with those patients is I make them take their blood pressure pills. I make them send me their blood pressure measurements, you know, regularly before, and make sure they're on their meds. And then I will prescribe stimulants. I make sure they have a home blood pressure cuff and keep an eye on it. Let me tell you, when their ADHD is treated, they often take their blood pressure medications regularly. They often look after themselves better. They often lose weight. They get more exercise, and they are better across the board, not only from ADHD, but the other disorders in life. My child is partying on the weekend. Don't give them their Vyvanse on the weekend. Oh, yes, please do. It is okay to combine with alcohol and cannabis. I'm not suggesting you do, but there is not a huge problem that we are aware of from studies. We do know that stimulants can make you be able to drink a bit more and not feel the effect. But I would want my ADHD patient to have better judgment and impulse control if they are using substances like alcohol or cannabis in social situations. Drug holidays are a good idea. Well, think of that word for a minute. Drug holidays. How many of you put your patients on insulin holidays? Or I'm sure Dr. McGeer doesn't put many of her patients on antibiotic holidays when she's treating an acute disease. You know, I think ADHD is a constant problem. And I think taking your meds 365 days a year, or 66 in this year, is really important. And I do think the brain functions much better. We do know that there's even some better development of a younger brain if they're on their medications regularly. So drug absences over the summer or weekends is not a good idea. I discuss it with patients. I try and dissuade them from that. And I have treated a number of people over the age of 60 who have been incredibly appreciative. And there are some studies suggesting that many people who have early cognitive impairment actually have ADHD, and it is kind of worth looking into as well. There's more studies moving into that right now. Next slide. 3 laminates available on CADDRA's website. These are the medication laminates. We update it regularly. There will be a new update soon. There is a new form of methylphenidate coming out to Canada in a couple of months, a liquid methylphenidate, but really helpful to have on the CADDRA website. Next 2 slides, the psychosocial laminates. Okay, and the next one, psychosocial laminate as well, very helpful. Now, I realize we're getting a little bit short of time. I'm hoping you get these slides. So let's just flip through them one after the other. Adderall and Vyvanse are not equivalent. 10 milligrams of Adderall equals 30 milligrams of Vyvanse. Remember that, a little pearl. Concerta, next slide. Concerta, the generic, is a nightmare. Make sure you write brand name and get them a copay card. 16-hour Foquest generally does not cause increased sleep and appetite effects. And then move on. I think we can just skip the rest of these. Oh, I'd like you just to know common errors in treatment: too low a dose of stimulant, not recognizing rebound when ADHD comes back midday when there's too low a dose, starting with an immediate release medication to see if it works. There is a surprising amount of Ritalin and Dexedrine still being prescribed in Ontario. There shouldn't be any being prescribed. Stay away from them. And I often will see people who get started on an SSRI or SNRI because they think it's safer, or maybe we'll just try that first. It just slows down getting to the cause of the problem. Flip through the rest of them. I'll stop talking. Women do have ADHD. Hormones affect it. You can treat ADHD and substance use. One thing that's important to understand, there are some really good studies that show that treating ADHD prior to puberty markedly decreases substance use disorder in children. Keep that in mind. ADHD is associated with obesity. Next slide. ADHD is associated with diabetes. Bet you didn't know that insulin-dependent diabetic mothers have a higher incidence of ADHD children for reasons we don't know. Far more type 2 diabetes in ADHD people and poor care of diabetes in ADHD people. And here are some resources. Okay, move on. Let's go to questions.
Sounds good. And actually, well, one of the questions, and I think it's reasonable as well too, actually, is if we could maybe just go back to the prescribing Pearl slide. I think actually, Joan, it might be helpful to just go over those because I know our audience was really looking for that in the Q&A.
Okay.
So it's okay. We can give you a few more minutes to talk about that for just some of these. So sorry, over here. So maybe these two. Why don't we go over those, and then I think then we can go to Q&A.
Okay, so in terms of treating ADHD, always start with a long-acting stimulant, no short-actings. For the vast majority, both methylphenidate and dextroamphetamine will work well. I do have there is an analysis that shows that methylphenidate is probably the best start for children and teens, that Vyvanse dextroamphetamine is probably the best start for adults, but it's kind of like 52%, 48%, so it's not a huge difference. It's very important to make sure that patients understand that dexamphetamine is not methamphetamine. Vyvanse is a prodrug. It is not easy to abuse it, whereas you can crush Adderall and abuse it. I have only 2 or 3 patients on Adderall. Vyvanse I use far more. Vyvanse is quite a bit. It has a lysine amino acid added to it, which creates quite a bit of weight in the lisdexamphetamine molecule. That is why they are not equivalent. So if a patient is on 30 or 40 milligrams of Adderall a day, they are on the equivalent of about 70 to 80 milligrams of Vyvanse a day. And one thing about Vyvanse, it is indicated for people with binge eating disorder. So if binge eating is a problem, I start with this. I will say I get slightly more problems with the dexamphetamine meds, Vyvanse, with anxiety, slightly more. So I'm mindful of that in an extremely anxious patient. I'll probably put them on methylphenidate first. And then maybe the next slide. So we have 3 long-acting methylphenidates. Bifenton lasts 10 hours, and it is great for children. Concerta is 12 hours. It absolutely positively must be swallowed whole. And so, you know, it's not helpful if a kid can't swallow, but you can teach them how to swallow. And then Foquest is 16 hours, and it lasts from morning till night. It does have a little dip in efficacy around 3 to 4 in the afternoon that can be problematic for some people. And I think that's as the beads of Foquest are going through the bowel and going, you know, into more the lower bowel where the beads are dissolved in sort of a more high pH area rather than the low pH area of the stomach. You can't crush any of these long-acting medications. They will not be released properly. Methylphenidate, I use, and again, I use all of the medications. Why don't we go to questions, because there's probably specific questions about them that I might best be able to answer.
Absolutely. That's perfect. Thank you. And thanks for taking the time to go over that, because I just know that there were a lot of questions related to that. So with that, you alluded to this a little bit, but maybe I'll just get you to restate it as well too, just around the prescribing trials of Vyvanse. So, you know, an attendee here is saying that many doctors they hear about are just prescribing it, and then if it works, continue it. But would anyone, ADHD or not, feel better and function better on a long-acting stimulant?
Well, I don't think just writing out a script for a stimulant is good medical practice. And, you know, I mean, I think if there are things that could get you in trouble with the college, that could, though I haven't seen it happen. Yeah, so I think you should do a proper assessment. Sorry, was there another part to that question?
No, that was it.
Yeah.
The next question here, and there's a few questions related to this, so I think you can answer them together, is around, I guess, the logistics with ADHD assessments and how it stands right now in Ontario. So Certainly a lot of these assessments are done privately. So, we had mentioned like, the psychoeducational assessments that you had mentioned. There's ADHD clinics. There's even ones that are led by nurse practitioners as well, too, because they're not part of the OHIP system. And psychiatrists also can charge privately for this, too. So I guess I think the bigger question is, in family practice, like, is this an OHIP covered service? Should we be charging privately? If we are, like, what is the standard rate for that? So maybe you could help us understand that a bit more.
I understand stigma. I know what the other part of that question was. People are thinking that if you give Vyvanse, people will just feel better. I don't think that really is necessarily the case. I think people who do not have ADHD will not notice as much of a difference from those stimulant medications. So I think the notion that just everybody feels good on a stimulant, I don't think is the case. I will say I have 2 children with ADHD. They are now adults and doing well, but I have gone the roller coaster ride. I have occasionally taken one of the stimulants. Does nothing to me, nothing. I feel nothing on it. I don't have appetite suppression, nothing. Back to clinics. Yes, it is difficult. I understand the pressure of being in family medicine. I totally get it. I've been there. And ideally, it would be lovely to sit down for an hour and a half session with your patient, which is what I have at the possibilities to do that. And if your patient is in a position to pay for an assessment, you can send them to us from all across Ontario. I'm not advertising. If you have a good relationship with a pediatrician, with a psychiatrist, even there are some very capable nurse practitioners who do assessments, foster that relationship. In terms of charging, I mean, in my situation, I bill OHIP. I do not extra bill my patients, but there is a charge I work with a nurse. And my nurse will spend a 3 to 4 hour session with the patients, going over all the standardized rating scales, taking them through it during the appointment, preloading all the history and whatever for me. So that does a tremendous amount of the work for me, which I know I could not have done in my regular practice. Or I spent 20 years doing ADHD assessments in the Scarborough Health Network. And, having to do all that myself, there's very different time management. In terms of how can you charge for this? I mean, you will bill OHIP your K codes. You could probably put an admin fee onto that for the questionnaires, reviewing information outside of that, or if you have staff that are able to help you with it. And, sometimes too, if you know your patients really well, I mean, I think back to the patients when I did primary care exclusively, I can think back to some who would ask me about ADHD, and I'd already know, yeah, you miss all your appointments, your kids haven't had their vaccines, you're very scattered, you forget to tell me what you really came in for. Sometimes you kind of know about that. And if you do make the diagnosis and you do get patients on medications, but you don't know what to do about psychosocial supports, if you have any clinics in your area where people can help them with psychosocial supports, great. I know that's difficult. There's a lot of good information on CADDRA and attitude, which I've given you in the resources. We will take patients for coaching without having done an assessment at possibilities, and we have some really excellent coaches and therapists, and coaching and therapy is not covered anywhere under OHIP. So but we do have good coaches, and coaches are there to sort of help them, like, this is the work you have to do. How are you going to get it done? How are you going to start on it? How are you going to manage it? And they help them get over what we call the wall of awful, the difficulty that ADHDers have on getting something started.
Well, thanks for that, and appreciate the perspective too, with you having been in family practice as well too, and being a family physician, because I think it's nice that you understand that reality, right? And
Totally.
the challenges that we have too. Something that's come up here too a couple times, I think, around a system level question is oftentimes ADHD referrals are rejected. Like, we see that from sometimes hospital teams, psychiatrists as well too. And curious, if you're aware of why that happens, like, is there some sort of reason why these assessments are not done?
It's very frustrating. So I chair advocacy for CADDRA. We actually have had a private members bill table to ask the government to help us really push for more education across the board for patients, for teachers, for healthcare clinicians, so that there's far more information, far more education, far more infrastructure to help this, because we really do need far more infrastructure. I mean, you know, it is quite appalling to me how difficult it is for many people to get an assessment. I mean, I would ask family doctors as much as possible to do the assessment if you can. I mean, we do as family physicians assess for depression and anxiety. And quite honestly, our patients with ADHD, if we figure it out and we start them on stimulants, do well, and they're incredibly appreciative of the work we do. You know, it is very frustrating when clinics and psychiatrists, et cetera, say they don't do ADHD. You know, and I think that, you know, if you're able to push back through your Department of Family Medicine within your hospital and say, look, we need some help with this, that's one thing to do. But I know even psychiatrists really struggle with this. None of us got much education about ADHD for the most part in medical schools, and psychiatrists get very little education about this as well. And yet there's a tsunami of patients who are really struggling out there. And we are in the process of trying to do a review of the education and knowledge base to really sort of, you know, help medical faculties with their curriculum. So in the background, we are advocating for all of this in CADDRA. It's a lot of work. And as you know, advocacy is a very long game and a very slow road.
Definitely, but appreciate all the advocacy that you're doing, because as you said, there's a lot of patients who need that help and that support, and it's often very tough for them to get it. So thank you for all that you do on that.
Yeah, and just if I can say anything, there is a risk to not treating ADHD.
Mm-hmm.
You know, all the things that happen to people in life because of their ADHD is quite profound. And the gratitude that I have got from patients, like, you have changed my life. Before, I never would have this, I never would have that. I wouldn't have graduated from engineering. I wouldn't have gotten my promotion. My marriage was falling apart. I didn't have a relationship with my son. I was flunking out at school. And now I'm functioning. I mean, the gratitude from patients is extraordinary.
Mm-hmm. And I guess the flip side to that question is, like, is there any risk if, let's say, we don't get the diagnosis right, or maybe, you know, the way the forms were interpreted, et cetera, or how the time it was done, maybe they don't have ADHD and we give them a stimulant. Is there significant harm with that? Like, what is the risk with that?
You know, listen, I will say that I have done sort of some thorough assessments on patients, and I've really been sitting on the fence about it. And, you know, so I'll say to them, look, you know, I'm not 100% sure, but we've done all of this, and this is what you're experiencing. And so let's do a trial and see. But I'm not promising you are going to. And, you know, sometimes you just don't, you know, and then I'll follow them. But I have, you know, got a recorded, you know, assessment on my chart. I mean, I have looked into it and I've discussed it with the patient.
Mm-hmm.
So yeah, I think to give them the benefit of the doubt is also okay. Yeah.
Mm-hmm. And I guess in terms of risks, though, like, are there risks in terms of, you know, complications if they're on these stimulants unintentionally?
Yeah, for the most part, stimulants are really pretty safe. So children have more side effects than adults, I would say. And a large part of the problem with children, if parents are taking the kids off and on medications on weekends, holidays, they have way more side effects of appetite and sleep, et cetera, because they're off, they're on, they're off, they're on. So regular use of the medications, less side effects. Interestingly enough, the appetite thing for adults, many of them are grateful because they're overeating, but they normalize their appetite quickly, or they're adults. I know I need to eat some lunch, I'll eat some lunch. For every adult who has a problem with sleep on stimulants, 10 of them tell me they sleep better because they don't have this rumination and stuff going on at night. So they actually often do sleep much better, and they settle down a whole lot better. So those are the two main things. I occasionally get like headaches and you know, jaw tightness, little stuff like that. I have not seen psychosis, maybe once, but this was a patient who I really think was in the process of developing schizophrenia. So obviously we took this young man off stimulants. I have seen some people who have had an uptick in their blood pressure and heart rate, more so with Vyvanse than with the methylphenidate medications. And so, I'll maybe change them to methylphenidate, depending on their age. Maybe they were developing a problem in the first place. They're really benefiting from the stimulants, then I'll have them talk to their doctor about maybe treating their blood pressure. But again, it's not often. And the abuse potential of the long-acting stimulants is not high. There's not a street value to the long-acting agents, other than generic Concerta, because that's just methylphenidate and waxy base, so they can actually get that out. And the stimulants are really sort of a poor man's substitute for, drugs of abuse.
Well, thanks for that answer there. Couple other questions here, and then we'll likely close things for today's session. So this question pertains to ADHD and pregnancy. So are there any ADHD medications that would be better for those either wanting to get pregnant, or do they need to be weaned off prior to getting pregnant if none of them are acceptable?
Great question. So I have managed many pregnant patients who stayed on their meds through pregnancy, and they've had no problems. And I've suggested, come off, don't come off. These are the risks and benefit. And often the patients will say, I'm not going to function very well. And I have seen, I had one really difficult to manage patient a number of years ago, lovely young woman who did come off her medications, and she developed a terrible postpartum depression. And there is a bit more postpartum depression in women with ADHD, but the risk of ADHD medications is very small in pregnancy. And there are a number of articles that say that they're probably quite safe to use. We know that there's about a 2% risk of some sort of congenital defect of some sort in any pregnancy. There's a 1% risk if you're using methylphenidate of maybe some minor cardiac defects, not great big ones. With Vyvanse, there seems to be a slightly higher risk of the baby ending up in the NICU after birth, but then coming through fine. So the risk is quite small. And I discuss it with the patients and say, there's a small risk. What many of them will do is they'll stop their meds in the first trimester and then come back on. Or if they're feeling like they're okay on their medications, off their medications throughout pregnancy, I'll often maybe encourage them to perhaps start them again in the month before delivering, because they're about to go into a very challenging time with a new baby at home. I remember it well.
For sure. And I think it sounds very much like similar to the approach that we take in the addictions world with, a patient with a substance use disorder in pregnancy and determining whether or not to maintain the medications, and that kind of patient-centered discussion around the risks, but also the benefits that come with treatment versus being off of it. So it sounds like you need to take that type of nuanced approach.
Yeah, exactly.
Excellent. And then the other last question that I'll ask you here is around the anxiety ADHD overlap. And you alluded to this a bit in your talk, but just to dig into it a little bit more, the person asking the question here says that I feel it's recommended to get anxiety under control first, but at what point in anxiety treatment can the ADHD medications be safely started, as ADHD symptoms will often aggravate the anxiety? And I know you had said, well, you should find out why they're anxious first, right? So
I actually don't think getting the anxiety under control first is the way to go. I think that you have to find out why they're anxious. And, if they have a global anxiety disorder, they're worried about climate change, they're worried about tsunami, they're worried about getting COVID, they're worried about drinking milk, that kind of anxiety, then maybe you do need to treat that anxiety. But if their anxiety is, I'm fearful during exams, I can't get my work done, I lie awake at night because, I'm so upset about how badly my life is going, et cetera, start them on stimulants. And for stimulants increase anxiety in probably 1% of patients. I changed a man from one stimulant to another yesterday because of anxiety, and he didn't have anxiety before he started stimulants. I would say I haven't done that in over a year, and I have an almost exclusive ADHD practice. More often than not, patients say to me, my anxiety is way less. I've had lots of patients say, I'm not anxious anymore. So I would, and you'll get a response to the stimulants relatively quickly. I mean, I do start at a low dose because I think if you start a low dose, there's fewer side effects, but I do move it up within a week or two. Like I move up every week to 2 weeks and try and get them up to an effective dose as quickly as possible. All right.
Excellent. Thank you for that. So with that, we'll bring up the slides just to put forward a few closing remarks here. And thank you so much for all of those answers, Dr. Flood. So very briefly here, just a reminder to everyone that the Can Treat COVID RCT is still ongoing. So if you have patients who have tested positive for COVID with symptoms starting within the last 5 days, they can be referred into this program. Next slide, please. Just a reminder, too, that the OCFP has created measles resources that you can take a look at. They're available on the website and will be circulated after today's session. Next slide. There are also other communities of practice that the OCFP offers, including the mental health, addictions, and chronic pain, as well as the Peer Connect mentorship program. Next slide. Also a reminder here that we have had many other sessions on a variety of topics, and here's a list of some ones that might be interesting to you if you want to revisit them. Next slide. And the website is here to access those resources, and again, will be circulated. Next slide. So the webinar recording, the Q&A will be posted soon. Our next community of practice will be on May 17th. And I want to thank all of you for your attendance, for your engagement. I want to thank our panelists for their excellent talks. And I want to thank our entire team as well, too, for putting together today's session. I wish you all a wonderful day today and enjoy the spring weather. Take care.